hospital. So she'll start the lecture on the module 19, module 18. What did we learn? Dr. Kamshar.
Good evening, everyone. Thank you, sir. So we'll look at the recap of module 18. Which was on the rational antibiotic use in COPD and asthma exacerbations, as well as bronchiectasis and aspiration. So what did we learn? We are going to actually look at understanding the definitions of COPD and asthma. When do you actually need antibiotics? How do you identify purulence and when it is actually not purulence? When to start and stop antibiotics. In bronchiectasis, understanding the phenotypes, understanding chronic airway infection as well as pseudomonas risk, and then the importance of airway clearing. Again, for aspiration, the difference between silent aspiration and chemical pneumonitis, the anaerobic cover discipline, the prevention bundle. So when we look at the basic definition according to the goal 2026 of COPD exacerbation, it is when the symptoms worsen over a few days to up to 14 days. And what would these symptoms be? There will be increased dyspnea, increased cough or sputum. Now, remember that whenever you're dealing with a patient who already has an underlying disease and comes in with increased symptoms, it does not necessarily mean that it is going to be infection. So you must remember the possibility of mimics like pulmonary embolism, acute heart failure, in some circumstances even pneumothorax, because those also should be kept in mind when the patient presents with worsening of symptoms. Now, the GINA 2026 definition of asthma exacerbation is acute or subacute worsening of symptoms. The symptoms of asthma, that is shortness of breath, cough, wheeze, or even chest tightness, and their lung function, which is compared with the person's usual condition. Now, remember something about asthma as well. In asthma, the triggers are not bacterial because it is an inflammatory process. It can also be viral triggers. So pollens, pollution, and even the importance of checking the adherence technique to the inhaled corticosteroids and whether the patient is actually taking proper medication or not should always be remembered when a patient comes in with increased symptoms or an exacerbation of asthma. Now, when we look at the usual COPD presentation, what would it be like? A 68-year-old patient of severe COPD has a history of 3 exacerbations in the past year, now comes with increased symptoms of cough, shortness of breath. The sputum has become more in volume, is now yellow colored, and the oxygen saturation on room air is around 90-91%. So, when the patient has come with increased symptoms, so first question that should come to your mind should not be a reflex to start antibiotic just because the patient has increased symptoms. The first thing should be whether are you really dealing with a bacterial infection? Is it a pneumonia or a mimic? When you're sending the sputum culture, is it going to change your change therapy, or is it going to make the patient better? And also, does this purulence or this increase symptom in itself, does it justify adding the antibiotic? So these questions should always be kept in mind when you're dealing with a COPD patient with increased symptoms or exacerbation. Why do we overprescribe? Because as a knee-jerk reflex, when the patient comes with increased symptoms, it is a therapy that the patient is. It is the method that the patient is sick, and you want to add antibiotic, so as to prevent further deterioration. But that should not be the case. Like I said, for an asthma patient as well, it could be an allergic trigger, it could be a viral trigger, so or it could be just an inflammatory trigger. So you have to know that the reason for the exacerbation of the symptom, is it really infective and does it require an antibiotic coverage? Now, when we look at the microbiological involvement in COPD exacerbations, true bacterial involvement is only in about 40 to 50% of exacerbations. There can also be exacerbations because of the respiratory viruses. These days, we are seeing a lot of H1N1, and also atypical pathogens, which can contribute to the exacerbations. So, looking at the COPD exacerbation pathway, it can be viral or an environmental trigger, and also possibility of bacterial infection. So, when it is a viral trigger or a non-infective trigger, the care should be supportive. You should look at the bronchodilator therapy. You should look at the problem, why it has occurred, rather than just adding antibiotic. When would you consider an antibiotic? When would you consider adding antibiotic? When the patient has presented with increased dyspnea, increased sputum volume or purulence. There is a moderate to severe exacerbation, and there is also a history of risk of bacterial infections in the past, or prior bacterial exacerbation. And antibiotic decisions should depend upon faster symptom improvement, reduced risk of treatment failure, as well as reduced risk of early relapse. But when you're adding antibiotics, never forget that antibiotics have side effects. They also lead to increased antimicrobial resistance, and there's always a risk of C. difficile infection. So all these factors should be kept in mind when you're thinking of a COPD exacerbation and addition of an antibiotic. Now, when are they justified? As per Goal 2026, I've just explained about the increase in the volume and purulence of sputum, any prior history of bacterial culture supporting the bacterial exacerbation of COPD, patient requiring respiratory support in the form of invasive or non-invasive mechanical ventilation. So it should not be routinely added. Very important to remember. And remember to always look for mimics whenever the patient presents with increased symptoms. The basic principles of empiric antibiotic choice always remain the same for all infections, including COPD and asthma exacerbations. That you should always look at your local antibiogram. When you are covering in a low risk setting, the common organisms that you should cover for are H. influenza, Streptococcus pneumoniae, Moraxella catarrhalis, and preferably oral therapy. For higher risk settings, patients with prior pseudomonas or gram isolation of previous gram negative bugs, history of frequent exacerbation, dealing with severe airflow limitation, or recent antibiotic or hospitalization. Now, commonly the antibiotics that we generally use in low risk settings can be coamoxiclav, doxycycline, or even azithromycin. In high risk settings, we can give IV coamoxiclav or BL-BLI combination. So the duration of therapy. Now, longer duration of therapy that was, initially given for about 2 weeks because the patient has come is not recommended. Gold says that, if you're treating on outpatient basis and the patient is relatively stable, then less than 5 days is also enough, up to about 3 days. And 5 to 7 days, depending upon, of course, if the severity is more, and assessing the response to treatment. Longer is generally needed in slower response when the patient has a large pneumonia or you're dealing with a resistant pathogen or any other specific complication. Now that is when only the longer therapy is recommended. Now, when we have the habit of thinking that broad spectrum means that it is a better cover. It is not. So you should not have the common reflex of coamoxiclav always. You can also use, like I said, doxycycline or azithromycin. So use the narrowest effective agent whenever you are thinking of therapy, because broad spectrum is also associated with more adverse effects, more development of resistance. So if you can avoid, try and keep your therapy, your empiric regimen as to the narrowest effective agent. So when we look at the stewardship checkpoints for COPD, first of all, identify you're actually dealing with a bacterial infection. Is it a pneumonia or are you dealing with a mimic? Narrowest, most effective agent should be the first drug of choice. Reassess the response at 48 to 72 hours. Look if you can de-escalate. Has your diagnosis changed? Does the patient really need the continuation of antibiotic or not? And stop if it is not needed. Or even, if you started initially IV and the response is good and there's no need for further continuation IV, you can even switch to oral. So that's what your reassessment should involve. Now, the long-term azithromycin in COPD, which is used as a prevention, it is only given in selected patients who may be frequently exacerbating despite optimized inhaled therapy, best in cases of former smokers. So now the goal of this therapy is it's not used as an antibiotic. It is basically used as an anti-inflammatory for the immunomodulatory effect of azithromycin. And the purpose of it is to basically prevent basically prolong the exacerbation-free intervals. But whenever you're starting this therapy, long-term azithromycin, you must check the patient's ECG, check for any QT prolongation, any hearing risk, any drugs that the patient is on, any risk of NTM or TB, and always review. If you have initiated this therapy, always review, and it can be given as a thrice weekly regimen for your COPD patient in a dose of 500 milligrams. Then for asthma exacerbations, like I said, they are not always bacterial. So there can be, the exacerbation can be because of a viral trigger, allergen, irritant, pollution. It can even be exercise induced. Or altogether, the patient there is poor adherence to the inhaled corticosteroid. Because the dominant biology in asthma is the type 2 inflammation. So I'm not saying that there cannot be bacterial exacerbations. There can be, but then you have to really look at the patient, take the history, clinically examine and correlate, and then see, are you really dealing with the bacterial exacerbation or not. So when you look at the asthma pathway for exacerbation, now asthma exacerbation, like I said, because it can lead to airway inflammation and bronchoconstriction. So the patient would present with diffuse wheeze. There will be variable airflow limitation on the uh, PFT. Then it is often triggered by allergens, viruses, exercise. So the management of this exacerbation would not be an antimicrobial. It would be inhaled short-acting beta-2 um, agonists, inhaled corticosteroids, and you may consider oral corticosteroids if the patient has a moderate or moderate severe disease. And you must treat the triggers and the comorbidities. The clinical presentation would be cough, increased shortness of breath, chest tightness, and even wheezing. Now, if the patient has a pneumonia and it is an infective exacerbation, then of course the typical symptoms of pneumonia and infection like fever, chills, malaise. Patient may have crepitations also on examination. The typical blood picture would have increased TLCs, maybe a increased CRP or procalcitonin, and chest X-ray may also show you a consolidation. So, of course, the management is going to involve initiation of antibiotics, but supportive care is also needed, and you have to give these patients as well the appropriate bronchodilators and corticosteroids if needed. So, what do you test in an asthma exacerbation? First of all, of course, you examine the patient, you look at the severity, then you do a chest x-ray, because when you are suspecting if there is a pneumonia, you need to see the chest x-ray as well. There could be a complication, there could be a pneumothorax. Viral testing is recommended only in the appropriate clinical setting. Like these days, we have a lot of H1N1. So, these days, yes, you should test for the possibility of a viral exacerbation as well. And appropriate sputum cultures, when you're dealing with an infection. So now in asthma, just because the sputum is green and it is increased in amount, it is not necessary that it is infective. Now this can also be because of the eosinophilic degranulation, which occurs because of the inflammatory processes that occur in asthma, which causes the sputum to become green. So that does not necessarily mean that it is the increased or the green sputum is because of the infection. Now, according to the GINA 2026, the routine antibiotics are not recommended. So, in any exacerbation of asthma, antibiotics are not treatment for bronchospasm, mucosal edema, and mucus plugging. So, that is what you have to treat when you're dealing with a patient of asthma exacerbation. And of course, like we discussed, if there are typical features of infection, then you do add antibiotics in an asthma exacerbation patient. And for a severe life-threatening asthma, you all understand what is a severe life-threatening asthma. Antibiotics are only added if there is a bacterial possibility. So even in the severe life-threatening asthma, that principle remains the same. So you must look for signs of pneumonia, sepsis, any focal signs, any consolidation on the chest X-ray. Just because it is a life-threatening severe asthma, do not jump onto initiating antibiotics. Although in routine practice it is done, but if you do start antibiotic, you must review and reassess that the life-threatening severe attack, was it really because of the infection, or are you dealing with the inflammatory and the allergic trigger which led to the asthma exacerbation. In that case, you can de-escalate at 48 to 72 hours. So to conclude, in COPD, antibiotics may help, but only when there is a bacterial probability. In asthma, you must treat inflammation and bronchospasm. Do not treat the sputum color, and use the narrowest and the most effective agent. shorter courses, and always reassess after initiating your antibiotics. Now, after the COPD and asthma exacerbation, we also covered bronchiectasis. So we all understand that bronchiectasis in India is it really matters, because in India we see a lot of post TB bronchiectasis, which remains a major phenotype. We deal with the common organisms like Pseudomonas, Klebsiella, Haemophilus, and NTM in very selected cases. So just to recapitulate, what does it mean pathologically? It is basically the permanent bronchial dilation, which creates poor clearance and repeated infection. Because of the mucus stasis, it becomes a substrate for persistent infection and inflammation. So what would it lead to? It would cause more exacerbations, cause worsening of the patient's symptoms, more repeated admissions to the hospital, and eventually, decline in the lung function. So the management of bronchiectasis and exacerbations always should not be only, focused on microbiology. You always have to remember the importance of airway clearance and prevention. They go hand in hand when you're managing a patient of bronchiectasis. For the etiology of bronchiectasis, post-infectious and post-TB bronchiectasis is very common in India. You must always remember to check for the immune deficiency, possibility of ABPA, any risk of aspiration or reflux, any autoimmune disease, any possibility of NTM or fungal disease. So, because the cause eventually, helps you to first obviously treat the patient and also in the prevention of recurrent exacerbations. Now, bronchiectasis is a vicious cycle. There is structural lung damage, there is tissue destruction, there is mucus retention. The mucus retention, and there is impaired mucociliary clearance. So, when there is impaired clearance, there will be more stresses of secretions, and more pathogens, more bacteria will grow. There will be chronic airway infection, so there will be bacterial colonization, there will be recurrent exacerbations. This will lead to further neutrophilic inflammation, more recruitment, so there will be more release of the inflammatory mediators. Again, what would this lead to? This would lead to more tissue destruction and damage, resulting in more airway dilatation, fibrosis, and loss of elastic recall. Again, because there is a structural damage, more mucus retention. So this is a vicious cycle which happens in bronchiectasis, and this is the very basis of this disease, which is why in bronchiectasis we deal with a lot of uh, um, more colonization and a lot of pseudomonas also in our country, because of the stasis of these secretions and the structural lung damage. So how do you recognize a bronchiectatic exacerbation? Change from the baseline, because these patients would have a little bit of cough or a little bit of phlegm. Change from their baseline matters a lot. So you must look for any worsening of the cough, the sputum, volume, consistency, any increased breathlessness. Sometimes patients even present with hemoptysis. And we've just talked, always consider the possibility of the mimics, pulmonary embolism, heart failure. That goes even in a bronchiectatic exacerbation, because it is not necessary that the patient has a recurrent exacerbation just because of infection. And like in any other infection, we say send the sample, so send the sputum before initiation of antibiotic. But if, however, do not delay your therapy just because you have to send the sample. And very important, prior microbiology should guide you for your first choice of antibiotic. So when you're dealing with an acute exacerbation of bronchiectasis, before starting, if you have a patient and if their past cultures are available, review the previous reports to see the resistance patterns, what bugs you've been isolating in that particular patient. Send a new sample as soon as possible and assess for the severity, and decide whether you want to give the patient oral or IV treatment. And like we talked about in the COPD and asthma, use the narrowest effective drug. For Pseudomonas, you cover when there is a history of previous isolation or you are strongly suspecting. Only in that circumstance you cover for Pseudomonas. So the duration of treatment and route, oral is suitable for mostly for the stable patients. And of course, the organism is susceptible and the patient can tolerate oral therapy. IV is recommended for more severe illness when you're dealing with more resistant pathogens or the patient cannot take oral therapy. Duration is usually 40 days, especially for Pseudomonas for severe disease. Now, Pseudomonas, again, like I said, is a high risk phenotype
पेशाब के थैली की
and
बॉल है ना,
it tends to cause chronic
ऐसे रहना
infection.
है.
It is
अभी क्या
associated
वो
with more
ऐसे हो
exacerbations,
गया
more
है.
admissions,
अब ऐसे हो
worse
गया तो ये
outcomes.
जगह में से वो पेशाब पास होने के बाद
Isolated Pseudomonas in a bronchiectatic patient, you must not ignore it. It is very important to consider eradication and airway clearance as well as optimization and prevention strategy. This remains one of the most
अभी क्या
important
करना है
aspects, especially when
वही
you're
दोनों में
dealing
से
with
एक
a
ऑप्शन
bronchiectatic
आपको
patient
सेलेक्ट
with
करना पड़ेगा.
Pseudomonas
अगर आप
in
इंजेक्शन
our
भी बोल
culture.
लेते हैं तो मैं लगा देता हूँ, सुबह शाम आके ले लो. आप बोलो नहीं मैं अस्पताल में
So,
एडमिट हो
as per the
जाएगा
ERS
तो 2-3 घंटे
2025
ही
also,
अस्पताल में एडमिट होना
it
है.
suggests offering eradication after a new Pseudomonas isolation, and the regimen would depend upon the
किडनी का नहीं है,
susceptibility, previous
किडनी से
therapy,
नीचे.
tolerability, and local practice.
वो ऐसे है.
So, what do you give in this normally? For the eradication, they recommend giving the therapy for up to 2 weeks. Initially, systemic therapy, followed by 6 weeks of inhaled therapy, and it can even be extended up to 3 months. But this would all depend upon the what your repeat cultures are showing you.
ये
So
ऐसा रहता
again,
है
the
अंदर तक.
2025 update about the inhaled
अभी क्या
antibiotic,
हुआ
like I
है,
said,
ये जो पार्ट है
anywhere after the 2 weeks of systemic therapy,
इतना,
6 weeks to up to 3 months,
इसके
especially with chronic
पूरे चारों तरफ
Pseudomonas
यहाँ पे
aeruginosa infection. But
घाव जैसे होके
like in a country like ours, when we
ये
already
जो
see so
है
much of
पैसेज,
antibiotic misuse,
ये पैसेज जो
it is difficult
ऐसे हो
to
गया है. एक
just start these
दूसरा
antibiotics and keep giving them, because you really have to 6 months, 3 months is a very long time, even
यहाँ
6 weeks of inhaled. So
ये
you must
पूरा
follow up these
इन्फेक्शन
patients
है,
and have a regular
भरा
check
हुआ है वो
that
इन्फेक्शन
if you
से.
have eradicated, you may even stop. There is no need
उसके
to
वजह
continue
से
even
वो राइट
for
साइड में
6 weeks if needed.
पेन कर रहा
However,
है,
when
उसके
you're
वजह
dealing with
से
a
वो
recurrent
सीधा
isolation
हुआ
and
है.
bronchiectasis, sometimes these patients keep growing
ये साइड
Pseudomonas.
खाली है, बट ये
So
यहाँ
again,
पे
for long-term
ये
macrolides, like
डिस्टेंशन
in
है,
COPD and asthma, even in bronchiectasis,
इसीलिए
ERS
वो
recommends
निकलने के
that
लिए
patients who
मुश्किल
have
हो रहा
high risk despite standard care, and those are the patients you give, and the therapy, the regimen is basically azithromycin
है, क्योंकि
250
वो दवा
milligram
से
daily
जाएगा
or
नहीं.
3 times weekly,
क्योंकि
or
दवा खा के
azithromycin
दवा क्या
500
करेगा,
milligram
वो
3 times weekly.
फिर से फोर्स डालेगा इस तरफ, फोर्स डालेगा तो पेन आएगा.
Now, I had mentioned
पेन आएगा, पेशाब
initially
नहीं
also when we
आएगा.
were talking about bronchiectasis about the airway clearance and pulmonary rehabilitation. It is even recommended strongly by the ERS 2025 that airway.
तो फिर सुबह शाम इंजेक्शन ले लो. ऐसे करना पड़ेगा.
कल शाम से करता है।
अभी
Is she disconnected?
अभी तो करना ही है, अभी नहीं करना है। अब थोड़ा
Yes, sir. I think she is.
फंक्शन भूल जाओ.
I think there was a
फंक्शन है
signal was going down.
दीदी का,
I'll just call her again. She can pick up.
वो उसका फोटो सब आएगा कल।
कल आएंगे ना. हाँ, अभी रात में
से डाल के रखा था।
हाँ तो उसमें क्या है. हाँ
उसका डिलीवरी है सामान।
वो उसके लिए रेडी रहना है ना.
कल शाम को आता हूँ।
I'm sorry, I think I got disconnected.
रेडी होने के लिए पहला
दर्द के लिए ये
कल तक, कल दोपहर के बाद कुछ हो गया आ जाएगा।
मैं नहीं बोल सकता कि वो कल तक
Yeah, I'm really sorry. I think I
बंद
got
रहेगा,
disconnected.
क्योंकि वो तो
So, I was talking about the airway clearance and pulmonary rehabilitation. Now, even ERS 2025 strongly
ये दवा
recommends
लिख के दे
that
देता हूँ,
airway
वो
clearance
स्टार्ट
techniques.
करो.
These should be
चल
taught
रहा.
to the patient. You
चल
have
रही.
to keep reinforcing on every OPD visit about these, because it is these really help the patient in overall preventing not only the exacerbations and repetition and their severity, but also in the overall symptom reduction of the patient. So you must teach the technique and then always review for the adherence. Similarly, for pulmonary
एंटीबायोटिक भी लिख के
rehabilitation,
देता हूँ.
it is strongly recommended, especially when the exercise capacity is impaired. Sorry. Then after the COPD, asthma exacerbations and bronchiectasis, we also learned about the aspiration syndromes. So for aspiration, the basic definition of aspiration is that it is the oropharyngeal gastric contents that enter the lower airways and lungs, leading to inflammation, infection, or respiratory complications. The risk factors for aspiration are impaired swallowing, reduced consciousness, history of reflux, any vomiting, patient on tube feeds, any
आके सो जाएगा बस।
reason for the poor cough reflex, history of stroke, dementia, or alcohol intoxication, patients with poor dental hygiene, and even recumbent position. So, silent aspiration can also occur, which can be missed. So, how would you actually know that the patient is
So
probably
I've
aspirating?
been
You know,
happy
when you're
ever since
feeding the
Saturday.
patient, the
Sunday I didn't have
patient
yoga, but
coughs
yesterday I
during
went
the
to work
meals
and everything, and
or
it's just moving on
while
onwards.
drinking water.
There
Generally,
is
these
me. I
patients,
took
they would
paracetamol
often,
and
even if
cetirizine
you take
from
the history from the
1 of
caregiver, they would tell
midnight
you that,
till
they
7.
cough more when we are giving
Now you are
liquids.
taking any
However,
medicine?
semi-solids,
I took
they
paracetamol and
tolerate better.
Yaparan, that's it.
So this is another very important history because liquids tend to spill.
After
So
that, any
that is when
fever
the
was there
patient
now?
coughs, especially
Yeah.
when there is a swallowing problem. So the history has to be taken
Now
in
also
detail,
it is there.
and you have to really observe this to not miss the
1.5.
possibility of
One not
silent
1.5 days.
aspiration. Also, if you see unexplained recurrent infiltrates in elderly or stroke patients, that could be another presentation wherein patient might be silently aspirating.
And feel here.
So when you talk about aspiration, aspiration can have a presentation of chemical pneumonitis or aspiration pneumonia. So what is chemical pneumonitis? Chemical pneumonitis is large volume gastric aspiration. What would it what would it cause? It would cause rapid onset hypoxemia or bronchospasm. Patient may have symptoms or may have like a little fever or sputum, and generally the treatment for this is supportive first, and you have to observe, not add an antibiotic. For an aspiration pneumonia, however, there is an infected aspirate from colonized oropharyngeal material. So, patient would have fever, productive cough, may even have increased TLCs or a consolidation on the chest X-ray. So you treat as per your local antibiogram and you add the antimicrobial here. So this is the difference between the two presentations of aspiration, and this is something that you should be able to identify. And when we talk about aspiration pneumonia, you select the therapy for like any other infection based on the local antibiogram, how sick is the patient, how severe is the pneumonia, and if you're dealing with any underlying disease or anything else which needs an appropriate antibiotic
Any
cover.
breathing difficulty you will
So
get
that is
now?
very
No.
important. And as far as the
It's just
anaerobic
weakness
coverage
is
is
there.
concerned, routine
It's
clindamycin
like
and
the acute viral
metronidazole are not
syndrome
required.
with the
You
upper
usually
respiratory
add
tract
these when you're
infection.
dealing with complications like
And give
abscess,
some medicine, take
cavitation,
that and see
necrosis,
today
or
and
even
tomorrow.
putrid
If it is
sputum.
not settling,
If
you
the
have to
patient
go for
already had
blood
a
test.
severe periodontal disease, or
I can
if
go now anyway.
there is
But I
Go
said
no
now.
once I go,
response to your
yeah.
initial
She
therapy.
can go,
So,
no
I can go
problem.
now.
routinely anaerobic
I'll
coverage
write
for
down your
aspiration
Anisha is
pneumonia
there,
is
so she will
not
also
recommended.
travel back.
So it will
Now, when we
come
look at the
around 1 hour
prevention bundle,
report.
the
Okay.
prevention
You
bundle
start
for aspiration
medicine
should
after
have
that.
swallowing
Sure.
strategy. You
I'm very
must
I'll
good.
write and give you
get
the
the
blood test.
swallowing
You
assessment
do it
done.
that.
So you can
Actually,
involve your
sorry.
ENT specialist. There's something known
Name, huh?
as PEACE, which is called the
Akanksha,
fiber
AKA,
optic endoscopic
NK,
evaluation of
SAP.
swallowing, which the
Age,
ENT
huh?
specialist can do
29.
for your patient to
Any
assess
medicine allergy
the
you have, ma'am?
No.
swallowing
Any
of the
regular
patient.
medicines you are
Then
taking?
you can
No.
modify the liquids in the food texture. Like I said, a lot of patients, they are able to swallow the blenderized soft feeds more than liquids, and supervised feeding wherever it is wherever the patient requires supervision. Always feed the patient in upright position. Avoid feeding in the recumbent position. And sometimes it is the feed volume. So if you're giving a large volume, maybe the patient is not able to tolerate, and there's regurgitation or through the tube. So you can reduce the volume of feed as well, and even the rate of
Any
the
medicine
feeding.
allergy you have, ma'am?
And
No.
of course, like I said, you must remember that when you're dealing with aspiration, you must take care of the dental
Do this
hygiene,
blood
regular
test.
mouth care,
CBC, CRP,
because
Vidal,
this will
then we'll
reduce
see.
the
Sure.
colonized
Okay.
oral secretions. And review your sedatives. Sometimes, when the patient is sedated, even then there can be silent aspiration. So, if the patient doesn't require sedatives, you must interrupt, like, which is also recommended in the
Understand.
ICUK bundles.
When you took last?
Just a word about the feeding tubes. So, normally when we give patient nasogastric or peg feeding, it definitely helps in nutrition, and in certain patients it can also help in the swallowing problem. But it does not automatically mean that now you have protected. Even the aspiration can even occur from saliva or from the regurgitated feeds. So you need to remember this. Just because the tube is in situ does not mean that the patient has automatically got protected from the aspiration. So you must, whenever you're feeding, you must keep your patient propped up. You must reassess, and you must, at all times, even when you're feeding the patient with the your nasogastric tube, reassess. So the final take-home message from the module 18 was that in COPD you use antibiotics when there is a bacterial probability, and keep your courses limited. Don't endlessly keep giving the antibiotic. If the patient is not getting better, reassess, look for the source. Maybe you're dealing with a non-infective cause. For an asthma patient, you treat the inflammation and bronchospasm. Always remember antibiotics only when there is a proven bacterial infection. For bronchiectasis and aspiration, you culture and you clear the airways to prevent exacerbations. And for aspiration, remember the difference between the chemical pneumonitis and the aspiration pneumonia, and keep your aspiration prevention bundles intact and teach that to your staff as well. Thank you.
Thank you, Dr. Akanksha, for my sharing is disabled. Can you give me sharing, please? So we'll start the today's proceeding and welcome everyone for this module number 19, which is on pleural infections and necrotizing pneumonia. And I have a great pleasure in introducing Dr. Arjun Khanna and Dr. Prashant Saxena to moderate this session. Both of them are eminent pulmonologists and intensivists. Dr. Arjun Khanna is head and senior consultant in the pulmonary medicine department, Amrita School of Medicine, Faridabad. He is a very well-known pulmonologist and very good clinician. He has done APSR fellowship in interventional pulmonology from Mahidol University, Bangkok, Thailand. He was the assistant professor in All India Institute of Medical Sciences. He's achieved a lot of awards and has received a Global Rising Star in Pulmonary Medicine, Lung Health Council, Nice, France, delivered more than 500 lectures and has more than 100 publications. His areas of interest: severe asthma, airway disease, pulmonary rehabilitation, and end-of-life care palliation. And he is co-moderating along with Dr. Prashant Saxena, very dynamic intensivist and pulmonologist. He is principal director and head, Department of Pulmonology,
Right side.
Critical Care and Sleep Medicine, Fortis Vasantpur, Gurugram. He's got multiple publications. He's faculty for the Diploma at National Board of Examination. Has been the examiner for MRCP. He himself has done FRCP and active in CMEs for Indian Society of Critical Care Medicine. He's organized n number of CMEs, extensive experience in ICU system and pulmonary interventions. He's been awarded Icon of Indian Medical Association, Delhi Medical Association Ratan, Buddha Peace Award, B.R. Ambedkar Prerna Samman, Times of India Healthcare Award, and Asian Patient Safety Awards. And his area of interest, of course, is critical care medicine, interventional pulmonology, sleep medicine, and infection prevention. Over to Arjun and Prashant.
Thank you so much, sir, for the honor of having both of us here. Such a pleasure being here. The series have been going on so well, and the lectures have been so well attended, and we have kind of learned so much from these lectures. It's a pleasure, and the best part is that Akansha repeats it every next week, so it's a double kind of a reinforcement which happens. Full marks to you, Akansha, for doing all the hard work. Every week I think that how much hard work she does, but it's commendable. It is fantastic. So today we have a very important session on two clinical problems which keep bothering us every now and then, and clinically sometimes very difficult to tackle, which is necrotizing pleural infections and necrotizing lung infections, empymas and necrotizing pneumonias. And as people get more immunocompromised, as we see more patients with transplants and people who've been on high-end chemotherapies, we do get to see a lot of these patients. And no matter how simple the guidelines are, or you are always in a fix. So the first talk would be by Dr. Avdesh Bansal sir. Sir is a senior consultant at Apollo Delhi, is the program director of interventional pulmonology there. Sir is a fellow of the Royal College of Physicians, Glasgow, of Royal College of Indian. He's a fellow of the Indian College of Critical Care Medicine. He's a fellow of the Physicians of UK and also of American College of Chest Physicians. And always a pleasure listening to you, sir. many years ago, I had taken a DNB exam together with you as an examiner, and I was scared, as a co-examiner of you at that time. So such a pleasure chairing you here, sir, today. And to introduce Manoj Goyal, sir, can I please request Prashant Saxena, sir, to do the honor?
After his lecture. No problem.
Yeah, all right, sir. So we'll start with Avdesh Bansal, sir, first. Sir will be talking about pleural space infections and empymas, something that I'm really looking forward to listening to. All yours, sir. Thank you so much.
Thank you, Arjun, for the kind. Can you hear me?
Yes, sir, we can.
Yeah. So thank you for the nice introduction, Arjun. Yeah, I remember that was a long time back. We took the DNB exam. I'd like to also thank Dr. Chawla and Dr. Katiyar for organizing this wonderful compendium of sessions, which is really teaching most of the budding pulmonologists as to how to treat these conditions. I'm going to talk about today about,
almost double
let me just share.
ಇನ್ಫೆಕ್ಷನ್ ಇದೆ ಸ್ವಲ್ಪ ಮೆಡಿಸಿನ್ಸ್ ಬರ್ಕೊಡ್ತೀನಿ, ಅದು ತಗೊಳ್ಳಿ. ಒಂದು ಸ್ಟಾಕಿನ್ಸ್ ಹಾಕಬೇಕು. ಇದೊಂದು
ಥರ
ಬರುತ್ತೆ, ಅದು ಹಾಕ್ಲೇಬೇಕು.
Yes.
ಖಾರ ಮಸಾಲ. So I'm going to talk about something which is what every pulmonologist see on a regular basis: parapneumonic effusion versus empyema. So recently we saw a patient who was 55-year-old, came with fever for 6 weeks, generalized malaise for 3 months, and he had been a diabetic for a long time. On examination, he showed that he had decreased breath sounds on the right side, and his CRP was normal. His CRP was raised, and he had normal TLC count. And we got his chest X-ray done, and you can see that there is decrease of the lung volume on the right side, with shadowing which is starting from top to bottom, but the CP angle is blunted, and there is some fibrotic band. So clearly we suspected some kind of chest infection going on for a long time. We got a CT done, and you can see the CT which shows collection of fluid in various pockets. So this is what looks like an empyema, and we started working up this patient. So empyema in Greek is known as pus in the chest. Simple. So what is the difference between parapneumonic effusion versus empyema? So parapneumonic effusion is something which happens when you have pneumonia, and you can have sympathetic fluid accumulation in the pleura. But this effusion is not necessarily infected, though it is exudative in nature, but is not infected. And these collections will normally resolve when you treat empyema. This kind of infection with antibiotics alone. So you don't need to do anything except give them proper antibiotics. Whereas when the infection travels to the pleural space and the fluid becomes infected, that is known as a parapneumonic effusion, which is complex or complicated. And this infection can be because of either pneumonia in the lung or direct trauma or iatrogenic causes, something like penetrating trauma or esophageal rupture or cancer or coming from abdominal sources. So in these patients, antibiotic alone are often insufficient, and you need to have drainage, which is very, very important. So if we look at the terminology, an uncomplicated or simple parapneumonic effusion is something which is free-flowing, and it is sterile. Important thing is that this effusion is sterile. Whereas a complicated parapneumonic effusion refers to effusion which is infected in bacteria or other microorganisms. And empyema as a term would be referring to collection of pus within the, so when you aspirate and you see frank pus, that is known as empyema. It could be because of either pyogenic bacteria, fungi, parasites, and in mycobacteria in our country is fairly common. And we call it complex effusion when we do an ultrasound and we see there are internal loculations, which could be either single or multiple. So a complex effusion is always a complicated parapneumonic effusion. So you need to remember this. When I use the term empyema loosely in this lecture, I would be mostly referring to complicated parapneumonic effusion. So what is the incidence? All the patients of consolidation, pneumonia present in the hospital, almost 20 to 40% of these patients will have some kind of pleural effusion. But out of that, only 5 to 10% will advance to empyema. And it's interestingly, it's very common in pediatric age group. There was a recent paper by the Banaras and the University group from the pediatric department. So they actually showed out of their 155 patients that number of these patients had almost 5 to 10% of the respiratory disease seen by them had empyema, and mainly malnutrition and interestingly poor immunization status was responsible for this. So it actually helps in telling you that if in case you improve their nutrition, in case you improve their nutrition, their immunization status, the incidence of empyema could become less in this patient. And as Dr. Akanksha told you in the last lecture, that the risk factors for empyema are mainly because of aspiration, poor dental hygiene, alcohol, immunosuppression, very young or very old age, partially treated pneumonia, and gastroesophageal reflux. And these are the important things. So, do you have to have pneumonia every time to have empyema? No, it's not necessary. As we have shown that 1/3 of patients with pleural infection have no consolidation. And that could be because of several reasons. Because the empyema can happen because of direct penetrating trauma. It can come from esophageal rupture. It can come from abdominal translocation, malignancy, post-procedure, like you had a lobectomy done, and you have a chest tube, and that gets infected, and you develop empyema. Urinothorax, okay, or coming from hepatic abscess, coming from splenic abscess. You don't have to have pneumonia, but you still have empyema because of these other infections, which result into infections in the pleural space. So what is the microbiology? And the microbiology, as we know that pneumonia is the commonest reason for empyema. So the microbiology is the same as of pneumonia, which is strep pneumoniae, almost causing 20 to 30% of empyema. Oral streptococcus and anaerobe causes almost 6 to 20%, and these are the ones which colonize the oropharynx. Staph aureus, especially in community-acquired paranoid confusion, almost 38% of these patients may turn out to be methicillin resistant species. You get empyema because of gram-negative bacteria also, Pseudomonas, Klebsiella, amounting to almost 8 to 17%. And this is happening because when you have translocation from abdomen, which is rupture or direct trauma, remember, atypical bacteria are rare causes of empyema, and that is the reason why when we give coverage for antibiotics, we do not cover atypical bacteria. But in our country, you need to remember, TB is a fairly common cause of empyema, and this was an interesting paper from 2007 from the Chandigarh group, which actually showed in 117 patients, almost half of their patients had tuberculosis. Fungal infections, especially Candida, almost causes 1% empyema. Candida albicans seems to be the most prevalent as compared to Candida glabrata and paracillosis. Also, again, I would emphasize that viruses do not cause empyema, but then when they get secondary infected, like we have the H1N1, we get a lot of patients who develop staph infections on top of that. They develop empyema. So it is not the virus, it is a secondary infection which causes empyema in these patients. So pathogenesis of empyema happens in 3 stages, but it's not necessary that every patient will go through these 3 stages. So the stage 1 is typically an early stage where the fluid is free flowing and small, and these will resolute with antibiotic. Stage 2 is fibrinopurulent stage where infection precipitates and then organization localization takes place. And stage 3 is characterized when it is not taken care of. The stage 2 is not taken care of. It results into thickened fibrinous coating that becomes a pleural peel, and that will ultimately limit lung expansion and will continue to have disease in these patients. So clinical features of empyema are like any of the features of pneumonia, but there could be acute, subacute, or chronic presentation. So cough, fever, pleuritic chest pain, dyspnea, and sputum are the usual presentation. But let's say you have a patient who has come with fungal infections. He will have a very slow presentation. Maybe it could be going on for 2 to 3 months. Tuberculosis typically goes on for a few weeks before it comes to the to the physician. Physical examination will show you presence of pleural fluid. And chest X-ray is something which is the first investigation, which is suggestive of some kind of empyema. But remember, it may be negative, and the reason could be sometimes the consolidation is big, it hides a small fluid accumulation. Sometimes the fluid is huge and it actually hides the pneumonia. So you may not be able to actually make a diagnosis of empyema only based on the chest X-ray. But when should you suspect empyema in such patients? When the fever persists, or there is a new fever, or there is lack of clinical response with appropriate antibiotics. So you must, at that point, suspect empyema is there. But like I said, chest X-ray is the most important thing. Now, normally, when you do a chest X-ray, you look at the pleural effusion, you'll see meniscal sign, okay, and the meniscal sign runs like this, okay. But in empyema, typically you would see a lenticular shadow, which means convexity, which is pleural based, and you can see multiple such shadows. Now remember, when the meniscal sign is seen on a TFL, the fluid is almost more than 500 ml, as compared to when you have a small amount of fluid, you can only see it on the lateral X-ray, and it can amount to only about 75 ml. So large effusion may hide underlying pneumonia, and large consolidation may hide small. So when you have absence of meniscal sign and you have lenticular opacities, then you must suspect that this patient may be having pneumonia. But CT scan is something which is very, very important, and CT scan is supposed to actually detect by even 2 to 5 ml of fluid, and that is what is claimed. So what does it show? It shows loculation very clearly, which are lenticular in shape. Okay, so you see these two shadows, and I showed you in my patient also that it has these lenticular opacities. The pleura is thickened, the parietal pleura as well as visceral pleura, and when you have a separation of parietal pleura and the visceral pleura by almost more than 3 centimeters, it is almost diagnostic of an empyema. And this is known as a split pleura sign, where you see the pleura is split into two angles. When you look at the angle is obtuse, and that is an important sign which is used to differentiate from lung abscess. CT scan is also important to diagnose other disease like a pneumonia, esophageal rupture, or masses that may show you underlying cancer. And also, if you've done a procedure like you put a chest tube in, it will show you the location and position of the chest tube. So it's really one of the most important examination to do in a ultrasound is something which obviously every patient would get done. Ultimately, when they have fluid, it's a bedside examination. And what do you see in empyema? You see a echogenic or separated pleural effusion, okay, which strongly suggests that you have a complicated parapneumonic effusion. So if you have a free-flowing fluid, it may be simple parapneumonic effusion, but if you see separated pleural effusion, there is a possibility that this is complicated parapneumonic effusion. So ultrasound is best utilized normally for selecting and guiding the needle or catheter placement, but also provides a prognostic and therapeutic information, because if you have a almost fibrosis kind of a stage going on multi-location, it tells you that this patient may have actually a difficult course in the future when you start treating. So this is some of the examples. This is a free fluid with a pneumonia. This is a debris in the pleural fluid, which actually tells you that this is a complicated parapneumonic effusion, and you see here multiple loculations, which clearly tells you that this patient has an empyema, and this is kind of fibrosis, which tells you that this patient will have a difficult outcome in future. So what investigation do you do? Diagnostic aspiration is obviously the most important investigation, but you always do a routine blood culture which can show you the TLC being raised, CRP being raised. Blood culture can actually sometimes grow bacteria, but it is not diagnostic. So diagnostic thyrochocentosis is the most important, which is almost always done under ultrasound guidance. Now, what do you do when you aspirate? Now, most of the physicians will actually aspirate completely when the effusion is small to moderate in size and it's not separated. And this serves both for diagnostic and therapeutic purpose. So once you've drained it, you've actually treated the patient. Continue with the antibiotics, patient will get better. Sometimes you drain large effusion because it is causing symptomatic symptoms like dyspnea. or when you have fractures. In those cases, merely aspirating the fluid will not be sufficient, and you will have to put a chest tube to drain these effusions. So, how do you diagnose empyema? So, clearly, if you see a pus, there is no doubt about it. pH less than 7.2 is something which is given in all the guidelines, but unfortunately, in Indian practice, I do not see many places doing pH. So it may not be a good marker for us, but glucose less than 40 milligram, an exudative infusion, LDH more than 1000, a count of more than 50,000, which is what is seen in empire most of the time. But if you find microbes on the direct smear or in culture, then clearly you're dealing with an empyema. So if you have a neutrophilic predominance, you're looking at bacterial pneumonia. If you have lymphocytic predominance, you most probably you're looking at tubercular or fungal etiology. ADA sometimes can suggest possibility of TB. A high LDH again suggests that it may be an empyema. So does pH of 7.2 always refers to an empyema? Not necessarily, because it can be associated with rheumatoid pleuritis, lupus pleuritis, esophageal rupture, fungal infection. But if you look at it carefully, in all these conditions, if you have a correction of fluid, it would be treated as an empyema and would be drained and then treated accordingly. Normal saline infusion, urinary fluorics, again can also give rise to pH of less than 7.2 and again needs to be differentiated from a proper empyema. So based on these tests, you have an uncomplicated parapneumonic effusion, which is a ultrasound-based free-flowing small to moderate size of fluid on the imaging. You have a neutrophilic exudate, but you have a normal pH, normal glucose level, and does not contain any microorganism. Okay, so the important thing is it is not infected. Just give antibiotics, and this parapneumonic effusion will disappear, and the patient will get treated. But if you have a suggestive imaging of a lenticular opacity, or you have on the CT scan, if you have the split sign, if you have multiple collections, if you have a pH of less than 7.2, if you have microorganism on the direct smear or in culture, and low glucose of less than 40, then certainly you're dealing with a complicated parapneumonic effusion or empyema if you have a pure pus drained, drawn on the aspiration. So the main differential diagnosis of an empyema is actually lung abscess. This is one of our recent patients where the upper cut actually shows something like an encysted effusion, but when you look at the low cuts, it was clearly a lung abscess. Right? The lung abscess tends to form an acute angle. Okay, so look at this angle. Okay, as compared to an empyema, which will show an obtuse angle. Okay, so that's not a definite sign, but it's quite commonly seen. Empyemas typically have a thinner or smoother wall as compared to lung abscess, which has a thicker wall and have irregular luminal or exterior surface. An empyema is likely to compress the adjacent lung structure. So when you do a CT, you actually see atelectasis around the empyema, okay, whereas lung abscess to erode adjacent structures. So what is the approach to treating these patients? I think in 2 lines, I can say prompt antibiotic initiation, drainage of infected fluid. That's the most important thing. But do you start antibiotic in every patient immediately? The answer is no. If you have a chronic empyema, patient who has come to you, let's say, like our patients, okay, which had symptoms going on for almost 3 months, fever going on for 6 weeks, you can wait for the results to come back before you decide what antibiotic you're to give. But if you have an acute patient, I trained in UK, and there it was a saying that even if in the middle of the night you suspect empyema, you treat there and then by putting or draining a chest tube or putting a chest tube. So it is a surgical emergency kind of thing. And if you wait, chances are that this fluid may become multiloculated and that the treatment may become more difficult. So what are the antibiotics? So I'm going to take this in 2 parts, antibiotics and drainage. So what are the antibiotics? So antibiotics obviously are started empirically, but then you have to cover things like Streptococcus pneumoniae, which is the commonest organism, or pathogens which are colonizing the oropharynx, which are like streptococci or anaerobic bacteria. So a reasonable option would include a third generation cephalosporin plus metronidazole. Okay, a beta-lactam or beta-lactamase inhibitor combination like ampicillin and sulbactam can also do. But if you have hypersensitivity or patients who cannot tolerate cephalosporin, a monotherapy with imipenem in these patients can also suffice. Or you can give a combination therapy with respiratory fluoroquinolones. So this is for uncomplicated diffusion. But if you have a complicated diffusion, so you need to expand your coverage to MRSA in patients like, these days we have a lot of influenza going on in patients developing pneumonia and empyema in these patients. You have to cover MRSA. Patients who have concurrent necrotizing community-acquired pneumonia obviously need cover for both MRSA and Pseudomonas empirically. And if you have a pneumonia and empyema developing in hospital setting, then in that case, you need to cover MRSA, gram-negative, and anaerobic bacteria. So a good example for these patients would be combining vancomycin and metronidazole with a anti-pseudomonas cephalosporin like ceftazidime, or you can combine vancomycin with anti-beta-lactam or beta-lactamase inhibitor like piperacillin tazobactam. In case you want to avoid nephrotoxicity, then rather than vancomycin, linezolid is a good alternative. So how long do you treat it for? You treat it for at least 2 weeks, and this is basically dependent on your clinical response. Sometimes the treatment can go on for 6 weeks also, and you switch to oral once you have satisfactory response, like patient is afebrile, hemodynamically stable, clinically improving, there is no drainage coming, and it is not needed, and the patients are able to tolerate oral. Remember, radiological clearance take a longer time, so you don't chase the radiological clearance, you chase the clinical improvement in the patient. So the drainage, second part, is very, very important because if you do not drain, patient will always have a poor outcome. And they will require more procedures. Eventually, they may need surgery and longer hospitalization. And this is particularly important for empyema, pure pus, where the prognosis is the poorest and it's got the highest mortality, almost 30 to 40% at times. So you must drain if you have positive pleural culture, if you have loculated pleural effusion, if you have a large free-flowing effusion, which is more than half of the hemithorax, if you have effusion associated with thickened parietal pleura, and if you have sepsis from a pleural source. So you must drain these patients. And how do you drain them? So if you have frank pus, you ideally put a single large bore ICD. Though interestingly, there was this trial, MIST-1 trial, which actually showed that there was no difference in mortality or need for thoracic surgery when you use a large, medium, or small size tube. But then the smaller tube needed more flushing, but they tended to get blocked. The only advantage was that they caused less pain. And in UK practice, I had seen all the time that physician would put smaller tubes, the surgeons will put larger tubes. So that would be the basic difference between surgeon and physician. Sometimes when you have loculation, you try and put ICD in the largest loculation and you try and aspirate the other loculation with needle. So you must assess once you've done this whether the drainage is coming properly or not. You look at the response, and when the ICD is having less than 50 to 100 ml of drainage for at least 2 to 3 days, that is the time when you decide and the patient is clinically improving that you can probably take out the ICD. So when do you give fibrinolytic therapy in these patients? The answer is if the patient is failed to improve. And how do you know that the patient has failed to improve? You have a residual loculation, a poor lung re-expansion. This is taken as evidence of treatment failure because the fever is persisting or the new fever is coming or there's persisting or worsening leukocytosis. And the imaging has clearly shown the tube is nicely placed. Catheter is in good condition, good position, but it's still not draining or it continues to be complex and poorly drained. So in these patients, if you're not being aggressive and you continue to leave them, then again the possibility of trapped lung will always be there in these patients. So you must be aggressive and treat them properly with fibrinolytic agents. So there were multiple trials for which have been recorded in the literature, MIST-1 and MIST-2 trial. The MIST-1 trial interestingly showed that streptokinase had no utility, and there was no difference in the mortality, and there was no difference in the use of the tube size. Whereas MACE-2 trial, done again in UK in 2011, actually showed, and there were 4 arms in this trial, which actually showed that it resulted into decreased rate of surgical intervention and lower hospital stay. So there was a 2019 Cochrane meta-analysis which actually showed, and this was the analysis of 10 randomized trial, which actually showed that whatever fibrinolytic you used, there was definite reduction in surgical intervention in these patients. So in our country, we do not have actually the combination of TPA and DNase because DNase is not available. So we still tend to use streptokinase, urokinase, and TPA, and they all work by working on activating the plasminogen to do the proteolysis. Whereas DNase, which is always given in combination with TPA, so what does DNA do? DNA increases the extracellular DNA, which increases the viscosity. So in combination with TPA, it actually works best. But we do not have the availability of DNase in our country. So what does the intra-pleural fibrinolytic therapy does? It reduces the need for surgery, shortens the duration of hospitalization, and obviously when you do this, you need to assess what is happening to the volume. Now, remember that you've done the ultrasound, you might find that, okay, there is 300 to 400 cc of fluid, and next day you come after doing this fibrinolysis, you find suddenly 1 liter of fluid is come. It does not mean that it was actually hidden. Sometimes the fibrinolytic itself can cause fluid production. So you must look at the clinical and radiological picture to find out what has happened to these patients. So once you're given a course, which is normally for 3 days, you must perform either a CT scan or ultrasound to look at whether your treatment has worked or not. And of course, the clinical picture will also tell you if the patient, in such cases, after 3 days of proper protocol of giving fibrinolysis does not work, if there's no response, then you're looking at surgical option in these patients, which is most of the time VETS, which is the minimal assisted thoracic surgery, and it actually is like removing the peel, making the cavity into one cavity, and making sure that everything is drained. And obviously, this will be used only in patients where antibiotics, tube thoracostomy, and a course of intrapleural fibrinolytic therapy has not worked. Okay, and these are the patients. So that's why in some of the centers, when a patient emphysema comes, they tend to involve surgeons earlier on, so that in case it fails, the surgeon is involved and he will come into picture. If you don't treat parapneumonic effusion, it results into fibrothorax, ultimately pleural calcification, trapped lung, and some of these patients who are not good candidate for any surgical procedure will end up having open window thoracostomy, which is a very, very horrendous procedure, which if you see these patients, they are cachectic and draining pus most of the time. So how do you classify what patient has got maximum risk? And if you see this rapid score, which is made up of 5 parameters, the renal parameter, age, virulence of the pleural fluid, source of infection, which is community acquired or nosocomial, hospital acquired, and the dietary factor in terms of serum albumin. So patients who have highest score, which is the 5 to 7, actually has significant 3-month mortality. It can be almost 30 to 40%. So this score in the beginning can help you decide as to this patient is low risk or high risk. So to summarize, treatment of simple parapneumonic effusion is empirical antibiotic therapy. Look at the clinical response in 2 to 4 days time. If it is good response, you continue treatment, turn them into oral, and if you find anything on the culture, you change the antibiotic. But if you do not find any response in these patients, which means complicated parapneumonic effusion, and the fluid amount is large, it is loculated, you put a chest tube, and you continue with empiric antibiotics, and you reassess them clinically after 24 hours. If they are continuing to do good, clinical response is okay, then continue with the drainage, and once drainage becomes less than 100 ml for 2 to 3 days. You remove the chest tube, and in the meanwhile, if you've got the results of your culture, and if it tells you to change the antibiotics, you do that, and then finally change to oral antibiotics when the clinical condition is better, and then follow them in an outpatient. But if the patient is not improved, then you must assess whether your antibiotic coverage is adequate or whether your additional drainage is required. Okay, in case you suspect inadequate antibiotic coverage, you repeat theracocentesis, you send the sample for culture again, but in the meanwhile, you change your antibiotic empirically to cover the anaerobic and resistant organism. You also check whether the drainage is complete or not. If it is not draining properly, then you think of fibrinolytic agents, and then again assess the response. And if the response is good by doing these two maneuvers, okay, then you continue with the treatment, and again wait for the culture results and decide. But if they do not respond, then surgery is the typical answer. So VETs in these patients would be the typical answer. So what happened to our patient? Our patient, we decided based on the CT scan that the pleura was very thick, and there was no way. We did the pleural aspiration, which showed 90% lymphocytosis. Protein was 5 grams, LDH was very high, ADA was 68, just suggested tuberculosis. And since the patient had been going on for almost 3 months, so we decided not to put actually chest tube in this patient. We decided to take this patient straight away for VATS decortication, which is done almost 7 days after the patient was admitted. And he did very well. The pleural biopsy showed necrotizing granuloma. The gene expert was positive, and the patient was started on UTT. And this is the X-ray 2 months after the treatment and VATS decortication. You can see that the clearance has not taken place completely. The patient is clinically perfectly fine. So you need to decide basically based on multiple factors. The most important thing is antibiotics and drainage of the fluid of pneumonia effusion, which is infected. Thank you so much. These are the references mainly from the BMJ best practice guidelines, American Institute of Thoracic Surgery, up to date, a number of Indian studies, which are interesting, mainly pediatric studies, not the adult ones. Thank you.
Thank you. Thank you, sir. Thank you for summing it up so well. And I think you've covered all aspects related to empyema and complicated diffusions, and all of these, we tackle all of them in our everyday practice. So I think, Chawla sir, we'll come to questions once the second talk is over.
Yes, I think he can stop sharing.
Okay.
You still not, it hasn't stopped.
How do I stop it?
There is a button stop sharing below.
Oops. Is the button stop sharing? ये पूरी बातें बता दिया करो.
So there's a control panel usually on the top. If you can see, if you just click on the top, there should be a control panel of Zoom. There will be a stop sharing coming just underneath. If you can see that. So can you see those icons of Zoom on your panel? Can you see that panel on your screen? Because we can't see that circle.
Stop share. Found it.
Oh, yeah.
Thank you. Yeah. Thank you.
Thank you, sir, and an extremely important topic and very well covered. And it's my pleasure to introduce our next speaker, Dr. Manoj Goyal, and he is Principal Director and Head of Pulmonology at FMRI Gurgaon. He has been accomplished and probably needs no introduction. He has been an organizing secretary for NAPCON. He's been the EC member for ICC in Delhi and NCR, and he organizing chairman for Haryana Resticon, TBCon, and other conferences. He is a convener of ICS monthly meetings, and he has probably written a lot of book chapters, including a book on bronchoscopy. He's an expert committee member for guidelines in bronchoscopy, EBUS, and he has many publications, and he has won several awards, including the Times Healthcare Achievers Award and ICCM Chairman's Award, NCCP Young Scientist Award. several orations in NAPCON and BronchoCon, and he has had research contribution in the Lancet and NEJM. And his area of interest are international pulmonology, bronchoscopy and EVAS, critical care, sleep medicine, and interventions. Not only this, he's been a teacher, mentor, guide for most of the young budding intensivists in the country. And more importantly, I would say he's one of the few gentlemen of pulmonology who's surviving to date. And thank you, sir, for guiding all of us. And over to you. Take care.
Thank you, Dr. Prashant, for such a nice pleasant introduction. And I must thank Dr. Rajesh Chawla and Dr. Akanksha for giving me this opportunity. And extremely impressed with Dr. Akanksha. I mean, the way she has been revising all the lectures in the CMEs, this is something mind-boggling. And all I can say is, may God bless her always.
Thank you, sir.
So, thank you, Rajesh Chawla, sir, for inviting us such an important CME session. And I pay my regards to Dr. Avdesh Bansal, who is mentor of many of us, and also pay my tributes and regards to my friend Dr. Arjun and of course Dr. Prashant, with whom we have been working very closely in FMRI. So let me share my slides. Yes. Visible. Yes. Right, so I think it's a full screen. So I'll be speaking on suppurative lung diseases. Suppurative lung disease infection actually represent an important spectrum of pulmonary diseases, ranging from necrotizing pneumonia, lung abscess, pulmonary gangrene, bronchitis. And although the antibiotics remain the cornerstone of the treatment of suppurative lung disease, but the outcome requires much more the antimicrobial therapy, and this is what we are going to, discuss today. So coming to lung abscess is clinically defined as a cavitating lung lesion filled with pus and necrotic tissue. It's typically occurs secondary to aspiration pneumonia, but it's a severe infection in a clinical blind spot because we don't have any active international guidelines on the management of lung abscess. The most recent randomized antibiotic trial was published in 2008, that was about 20 years ago. And despite severe morbidity, the management of lung abscess entirely lacks high quality evidence. So currently the clinical management remains unstandardized as far as the management of lung abscess is concerned, and treatment is driven almost entirely by retrospective cohorts and case report, despite there is high morbidity and mortality in these patients. Now there is also a big research void as far as the lung abscess is concerned. So if you look at the bronchiectasis, non-tuberculous mycobacteria, and the tuberculosis, for the last 50 years, while these entities have got an exponential growth in the research, whereas the lung abscess remains a highly neglected condition with flat line of the publication. So there hardly any publication which is going on lung abscess. Therefore, the knowledge about lung abscess is really poor. But the plus point is there is historical reversal of lung abscess mortality. In the pre-antibiotic area, the mortality rate used to be more than 50%, and the desperate surgical salvage in the form of a Neuhaus one-stage open drainage used to be the primary intervention. But in the modern era, the mortality has come down to less than 15%. The surgical intervention is now really required in less than 15% of the cases. This paradigm shift has been actually brought about by the introduction of the antibiotics, especially the penicillin, clindamycin, which have inverted the clinical pathway in these patients, and surgery, which used to be the primary cure in earlier days, now has become just a salvage therapy reserved strictly for antibiotic failure cases. Coming to the diagnostic criteria for necrotizing lung infections, the differentiation between pneumonia, lung abscess, gangrene, and septic emboli is largely dependent on radiography and clinical hallmarks. Now, there are two distinct pathways to pulmonary necrosis. One is infection of the lung parenchyma, other is the infection of the pulmonary vasculature. The infection of lung parenchyma leads to a progressive scale of parenchymal damage, tissue necrosis, and liquefaction in the form of lung abscess, necrotizing pneumonia, and pulmonary gangrene. And this spectrum, the pulmonary gangrene is the most severe form, whereas the lung abscess may be the least severe form, and the necrotizing pneumonia, lies somewhere between. But this does not show the continuum of the disease process. The patient can have a necrotizing pneumonia of low intensity, it can become a lung abscess of severe intensity, and then it can progress to very severe pulmonary gangrene. So it's not a continuation spectrum, but usually you will find the severity spectrum is something like this, that the least severe would be lung abscess and the most severe would be pulmonary damage with higher mortality and morbidity. The infection of the pulmonary vasculature occurs because the septic pulmonary emboli, which causes occlusion of the pulmonary arteries by these infected emboli,
And this is independent of the primary airway infection. Now, coming to the lung abscess, which usually presents an indolent solitary cavity, the clinical presentation would be that these patients would typically present with weeks of fevers and sweats before presentation with indolent course. And the radiographic hallmark would be a necrosis contained within a single large cavity lesion, usually isolated to a single lobe. So you find this cavity with a fluid level of necrotic material. The necrotizing pneumonia generally present with acute microabscesses. The clinical presentation is that they would manifest with severe clinical illness, high inflammatory markers like leukocytosis, elevated CRP, and sepsis, and there would be higher rates of hemoptysis and complicated parapneumonic effusion in necrotizing pneumonia as compared to lung abscesses. The radiographic hallmarks include diminished parenchymal contrast, as you can see here, because of the poor perfusion and compromised vasculature in these patients. There is presence of multiple microabscesses, as you can see here, and more importantly, there is a multilobar involvement with extensive airway disease. So the multilobar involvement and multiple microabscesses are actually differentiated from the lung abscesses. The pulmonary gangrene is the terminal parenchymal liquefaction, is the final stage of necrotizing continuum, driven by uncontrolled bacterial replication and exotoxin, especially the Penton, Valentine, Leucocity, and Staphylococcus aureus, and serotype 3S Streptococcus pneumoniae, causing massive alveolar macrophage dysfunction. The radiological hallmark of the pulmonary gangrene is that there is extreme extent of necrosis, defining more than 50% of the affected lobe. And if you do CT pulmonary angiography in this patient, then you may find presence of large vessel thrombosis also. The septic pulmonary emboli is sort of an outlier because it occurs because of vascular occlusion. The clinical presentation is driven by embolic source rather than a primary airway microaspiration. And most commonly, it originates from the tricuspid valve infective endocarditis, especially in IV drug abusers, and those with infected catheters. The radiological hallmarks of the septic emboli would be bilateral pulmonary nodules, which would be seen in more than 80% of cases, and more than 50% of these nodules you will find there is a cavitation, and there would be a wedge-shaped opacity, which is because of the pulmonary infarct, and you may find the feeding vessel sign, where a feeding vessel would be leading to some of these nodules. This is one case of septic pulmonary emboli. This was a 20-year-old male patient with a history of IV drug abuse, and he presented to us with high-grade fever, dyspnea, hemoptysis, left-sided chest pain, and hypoxia. The echo showed vegetation over the tricuspid valve. As you can see, it is floating over there. So this patient had tricuspid valve infective endocarditis with the IV drug abuse as the precursor. And the contrast CT scan, this patient showed multiple nodules, with some of them showing cavitation, as you can see here. And this patient also had a mycotic aneurysm of the left inferior pulmonary artery. You can see this is a dilated inferior pulmonary artery, and this is what we call as a mycotic aneurysm. And distal to this mycotic aneurysm, there was a necrotizing vestibular infarct, which was also visible there. So this patient was highly toxic and was very difficult to treat as a matter of case. So after stabilizing the patient with IV antibiotics for 2 weeks, this patient was subjected for tricuspid valve replacement. And the histopathology of the tricuspid valve show the colonies of Staphylococcus aureus. So these blue dots are actually the colonies of Staphylococcus aureus. And this patient requires 6 weeks of vancomycin following the surgical intervention. Now, coming to classifying the lung abscess, they can be classified as primary when they arise in patients predisposed to aspiration, or they could be secondary lung abscess, which occur as a complication of pre-existing local or systemic condition. For example, patient who are having endobronchial obstruction, maybe because of the foreign body lost many years ago, or these patients may have bronchogenic carcinoma causing the obstruction of the airway, or in patients who are immunocompromised like HIV infection. And as the duration is concerned, they can be classified as acute when the symptom duration is less than 4 to 6 weeks, and chronic when the symptom duration is more than 4 to 6 weeks. The pathogenesis cascade basically involves lowered consciousness and microaspiration, saliva, and oral flora, and this depends upon multiple factors, which may be endogenous and exogenous. The endogenous factors include the immunocompromised state like HIV infection or patients who are immunosuppressive therapy, neurological disease like Parkinson's or myasthenia gravis, and also patients with a structural lung disease like COPD. And the exogenous factors include overuse of sedatives, alcohol misuse, and poor dental health, and all these things lead to the increased risk of aspiration of the oropharyngeal flora. And these oropharyngeal flora then cause a polymicrobial proliferation. The bacteria multiply in the alveoli, various toxins are released, local inflammation triggers a massive neutrophilic response, which causes inflammation, and the bacterial coagulase and protease enzyme lead to small vessel obliterative vasculitis and thrombosis, which then lead to liquefaction and cavitation. There's a pericardial necrosis which occurs. The liquefied tissue communicates with the bronchial tree, causing classical expectoration of all sphenic sputum, leaving a cavity behind. This is anatomy of the lung abscess, which has a sort of a fibrotic wall, which is a thickened fibrotic tissue surrounding the lesion. The clinical implication of fibrotic wall is that it restricts the blood flow, severely impeding the antibiotic penetration into the cord, and therefore we require prolonged duration of antimicrobial therapy in these patients. And this also has a necrotic core, which is a liquefied purulent debris and dead neutrophils. The clinical implication of the necrotic core is that it provides a hostile hypoxic environment where the indolent anaerobes survive and thrive. And therefore, again, these patients would require prolonged courses of antibiotics because the poor penetration of antibiotics in this necrotic core. And then there is a communicating bronchus, the site where the abscess has eroded into the airway, and the clinical implication is that it causes radiographic air fluid level and the sudden clinical expectoration of putrid foul tasting sputum. Coming to the microbiological spectrum, the necrotizing infection can be caused by anaerobic anaerobes and the mixed flora and aerobes. The anaerobic infection most commonly caused by the bacteria and Fusobacterium. These are the very common anaerobic infections, and they are associated with indolent presentation, foul-smelling sputum, and they would have a classical history of aspiration, whereas the aerobes would present with more aggressive and acute presentation, and they are associated with rapid onset of high-grade fever, extreme toxicity, and many a time these patients do not have any putrid secretion following smelling sputums. The commonest aerobes include Streptococcus pneumoniae, Klebsiella, Pseudomonas, and Staphylococcus aureus, and these can be deadly, especially if the patient is immunocompromised. But what we get is usually a mixed flora of synergistic infections of both anaerobes and aerobes. That is something that we see classically in our patients. So the anaerobic infection would have a more indolent chronic course, whereas the aerobic infection would have a more aggressive and acute course, and these patients at high risk of mortality. Coming to the clinical profile, which is based on 222 hospitalized patients in Denmark, and typically this study showed that these patients would be having an average of 65 years. Majority of them would be male with prevalence of 63%, cough with 79%, malaise with 61%, fever with 57% were the commonest presenting symptoms. There was more of the right-sided predominance occurring 30 to 40% of the patient. Majority of the time the abscess was single, and the average median size of abscess used to be 5 centimeters in this study. And this study showed that the median hospital stay was 14 days, and the median antibiotic course required 38 days, and there was 16% mortality at 12 months. Expanding further the clinical presentation, the patient would generally present with intermittent fever, severe prostration, weight loss, and night sweats, which would be more than 2 weeks. They would be having productive cough, and the expectoration would be characteristically putrid and foul smelling. And occasionally there will be history of hemoptysis, especially if the patient has got a necrotizing pneumonia. On physical examination, there will be coarse crabs, and there may be absent beds on in affected severity depending on the large area of involvement. Also, if there is a syndemonic blood effusion. And in chronic cases, you may also find digital clubbing. Coming to the radiological diagnosis of necrotizing lung infections, the contrast-enhanced computed tomography remains the gold standard for morphological diagnosis of necrotizing infection. As a CT evaluation remains the definitive tool for localizing the lesion, so you can mark where the lesion is, whether it's in the upper lobe or the lower lobe, which side. And it's also crucial for measuring the cavity size to guide the drainage decision. So if the cavity size is, say, more than 3 cm or 4 cm and not responding to treatment, then these patients may become a candidate for drainage. And can also identify the complications like pulmonary artery aneurysm, pulmonary artery thrombosis, or maybe syndemonic effusion, as you can see in this patient. The ultrasound is a very important emerging modality point of care, especially in intensive care units. The ultrasound enables early detection of abscesses hidden with the consolidated parenchyma. It facilitates daily ICU bedside monitoring without shifting the patient to the CT scans, and it can detect lesions missed by the standard X-ray with zero radiation burden. Now, coming to a radiology picture of the lung abscess, it generally presents a solitary indolent cavity. There will be a fluid level in the cavity, and it's usually isolated to a single lobe. As far as the radiology picture for necrotizing pneumonia is concerned, you find the areas of low attenuation with degrees enhancement. There is a multilobal involvement, particularly the right middle lobe and lower lobe, which is the commonest, and then you have these multiple macro abscesses. In the septic pulmonary emboli, you find bilateral nodular opacities, which occur in more than 80% of the cases, and 50% of these nodules would be cavitating, and you may find this feeding vessel sign and also the bed-shaped opacity suggestive infarct. The microbiological diagnosis is also extremely important, and the sputum culture remains the traditional baseline investigation. It is non-invasive, widely available. But the problem with the sputum culture is there is a high false negative rate of more than 50%, and there's also a massive risk of oral flora contamination, and that makes it difficult to understand whether it's a real flora from the lung abscess or necrotizing pneumonia, or it is just a contaminant. To solve the culture yield deficit of sputum, now we have the NGS, of course, available in some of the hospitals. The NGS sequences all genetic material, and especially if you get the material from the percutaneous spread, that becomes more diagnostic. The advantage of the NGS is that it identifies exact pathogens despite previous antibiotic use, differentiates true infection from mere colonization, and it can also help in antimicrobial stewardship. The bronchoscopy is traditionally indicated to rule out the underlying neoplasm or cancer, or if you are suspecting a foreign body, or if there is unusual pathogen like tuberculosis and aspergillus. But as a matter of fact, I would do routinely a bronchoscopy in all these patients because we want to have an early microbiological diagnosis in these patients, and also we want to rule out tuberculosis, which is so much endemic in our country. But I generally do not perform a therapeutic bronchoscopy in this patient to drain the pus because there is a spillage risk. The therapeutic manipulation during bronchoscopy can inadvertently release large volumes of pollutant material into the other lung segments, risking various complications like aspiration, pneumonia, and even ARDS. And the results of the bronchoscopic drainage is also not very great, as a matter of fact. But this is one case where the bronchoscopy really helped. This patient came to us with a history of high-grade fever, and this patient had this right upper lobe necrotizing pneumonia, and already the patient received 2 weeks of antibiotics, and he was having relentless fever. And we performed a bronchoscopy in this patient, did the cryo extraction of an impacted incipient mucus, which was blocking the right upper lobe bronchus. And after that, patient responded very well to the antimicrobial therapy. This is the except before the treatment. And after 2 weeks of the treatment, there was significant radiological improvement, and the patient also clinically improved. Coming to the conventional antibiotics, the clindamycin remains the gold standard. It is supposed to be superior to penicillin because of its effect on the beta-lactamase producing anaerobic, especially the bacteroids. The dose is 600 milligram IV 8 hourly initially, and then we can de-escalate to the oral dose of 300 milligram QID for a few days or few weeks later on. The ampicillin and sulbactam is the traditional broad-spectrum antibiotic which is used in these patients. It is highly effective for hospital-acquired cases and also community-acquired cases, covering both gram-positive and gram-negative infection and also the anaerobic bacteria. The moxifloxacin is a convenient alternative to ampicillin sulbactam, and clinically is as effective and safe as ampicillin sulbactam with a highly convenient single-dose regimen. But majority of time we take a lead from the community-acquired pneumonia or hospital-acquired pneumonia guidelines because we don't have standard guidelines for the lung abscess. So if there is a community-acquired infection, then our core regimen would be ampicillin sulbactam. But important thing that we use a higher dose of 3 gram of ampicillin sulbactam 6 hourly. So we use a 12 gram of dose per day. And if we suspect a hospital-acquired infection, then our core regimen would be a piptazo or a carbapenem covering the pseudomonas. We offer the MRSA coverage if there is a flu co-infection, the history of IV drug abuse, a prior MRSA, and if my hospital has a prevalence of more than 10 to 20% of MRSA. And we use either linezolid or vancomycin for the MRSA coverage. Now, what to choose, the vancomycin or linezolid? So there is a bit of dilemma here, because vancomycin lyses the bacterial cell walls, it sort of bursts the cell wall of the bacteria, which may theoretically trigger a massive release of inflammatory components and preformed toxin to the lung parenchyma, which can increase the lung injury. Whereas the linezolid inhibits bacterial protein synthesis and reproduction without lysing the bacteria. It suppresses the production of the toxins, especially the PVL, and it minimizes the extreme inflammatory response. So generally we prefer linezolid over vancomycin. But the large RCTs are still needed to confirm superiority of linezolid over vancomycin, and we should not forget that clindamycin also shares these toxin inhibiting properties, and plus it has got a good anaerobic coverage. Coming to duration of pharmacotherapy, now generally when we start an effective antimicrobial therapy, the initial clinical improvement occurs within 3 to 4 days as the fever begins to break. By 7 to 10 days, we would expect complete apyrexia in these patients, and by 3 to 6 weeks, we would expect a radiographic resolution. So the rule would be that we start off with intravenous therapy until the clinical response occurs, and usually it takes about 2 weeks, and then we transition to the oral therapy and treat the patient continuously until there is a complete radiological resolution or a small stable thin wall lesion, maybe less than 2 centimeters is there, to prevent any sort of relapse. We assess the patient at 10 days. If there is a persistent fever beyond 7 to 10 days, that indicates that possibly there is a therapeutic failure and it mandates the immediate re-evaluation. And then we do a diagnostic checklist for the failure. It may be an inadvertent factor, like if there is a large cavity of more than 6 centimeters, then we know these patients would generally require a prolonged therapy. There could be obstructive factors like if there is a foreign body or neoplasm which may be blocking the natural drainage in this patient. In these cases, therefore, the bronchoscopy becomes mandatory. And there could be a microbiological factor that the pathogen may be resistant, or there may be other organisms like mycobacteria and the aspergillus which may require different kind of antimicrobial therapy, or there could be an alternative diagnosis like if there is a non-bacterial cavity disease like lung infarction, vasculitis, or could be an emphysema bulla which is filled with fluid. Now, percutaneous drainage is an important minimally invasive, surgical procedure which is done. I won't say it's a surgical procedure because it's done by the interventional radiologist. Maybe done in ultrasound room or maybe in the CT scans. So the indication would be if the patient remains non-respondent after giving at least 7 to 10 days of antibiotics, then we may consider, draining this pus. So the indications of the PCD would be complicated abscess with ongoing sepsis. If there is a progressive enlargement of the cavity leading to the risk of rupture, failure to wean the patient from ventilator if the patient has got a lung abscess, or in patients who are too critical for thoracic surgery, then we can perform PCD as a salvage therapy. It's considered to be highly safe and effective and can be done, as said, under the CT guidance or the ultrasound guidance by the interventional radiologist. And there is a fear that can cause serious complication, but those complications are extremely rare. What we talk of empyema and bronchopleural fistula is very, very rare, in the experience time. So this patient of ours had a, large lung abscess and did not respond well to the antimicrobial therapy over 2 weeks' time. And then we put this pigtail catheter and drained this abscess, and after that the patient responded very well to the treatment. He did not require any surgical intervention further. Now, coming to the surgical tipping point, the important thing is aggressive medical management has a very good, outcome. As a matter of fact, the mortality risk is only 8%, where the surgical resection has a higher mortality of 15.4%. And therefore, the surgical intervention is used only as a last resort, particularly in patients who got a persistent fever, despite 7 to 10 days of IV antibiotics. If there are anatomical factors like the cavity size more than 6 centimeter in diameter, or there may be endobronchial obstruction, or there may be resistant organisms. But these may be the relative indications. But the strong indication would be if there is a severe parenchymal destruction and necrosis, and at this stage we believe the cavity is permanently beyond the reach of systemic antibiotics, then we offer surgical resection in these patients. Like this is a patient where the lung is absolutely destroyed, necrotic, this filled with putrid pus, and you don't expect the antibiotics to work in these patients. This is a resected specimen in one of our cases. This is the one case where there was a large abscess in the right upper lobe. The patient continued to be toxic, and we did put a percutaneous drainage in this patient, but the pus was very tough and thick. So underwent this patient continued to be toxic, so he underwent a right upper lobectomy, and then his life could be saved. Another patient with necrotizing pneumonia, the patient had uncontrolled diabetes, and he presented to us with recurrent cough, fever, and mild hemoptysis. And you can see there is a necrotizing abscess there. And within the cavity of the abscess, you can see there is a mycotic aneurysm. So this patient was, in fact, at a very high risk of bleeding. And therefore, this patient, this is another view of the mycotic aneurysm. And this patient then underwent the left lower lobe lobectomy. Coming to radiological and clinical mimics of lung abscess, please remember that not every cavity with fluid level is a lung abscess. Especially, you have to rule out squamous cell carcinoma of the lung, especially if you got this kind of a lesion with the necrotic material inside, without a fluid level and non-dependent areas, and with the wall, especially the inner wall, which appears to be nodular, then there's a high suspicion this could be squamous cell carcinoma and not a lung abscess, and these patients would require, surgical or the biopsy and the further treatment. Chronic tuberculous cavities can present with large cavities, but usually they will be thick, irregular walls with surrounding parenchymal scarring and volume loss, and there will be strong predilection for apical and posterior segments of the upper lobes. Then this is the air crescent sign, which is classically seen in invasive aspergillosis. Then you've got this reverse halo sign, which is seen in patients of cryptogenic organized pneumonia. These patients, in fact, require heavy dose of corticosteroid rather than antibiotics. Then this is a necrotizing bronchiectasis, which look like lung abscesses, bilateral lung abscesses. But this patient, this is actually a necrotizing bronchiectasis. And we performed a bronchoscopy in this patient. And actually, we could see the, the, the right upper lobe bronchus was absolutely eaten up. And here you can see is the picture of the bronchial tube was similar to what we saw on the CT scan. So it is all sloughed out bronchial tree, and you can see a lot of debris. And this patient grew this typical cotton wool colonies of mucor. Another very interesting case, this patient we were referred to see, and this looked like the pneumothorax or maybe a cavity, but this patient in fact had undergone a gastric pull-up surgery for esophageal carcinoma. So what we are seeing here is a pulled up stomach and not a lung abscess. Therefore, proper history and examination becomes very, very important. So coming to the negative prognostic factors, a cavity diameter more than 6 centimeter, a cavity which is progressive to necrotizing pneumonia or gangrene, associated bronchial obstruction, immunocompromised status, age of extremes. So these are the negative prognostic factors, and these patients may require a very aggressive treatment. Coming to the final takeaways, the era of high lung abscess mortality is now over, with prompt microbiological identification and targeted prolonged antibiotic therapy of 3 to 6 weeks. Over 85% of cases resolved medically. The success relies on the discipline to wait for medical resolution while maintaining the vigilance to recognize the precise moment of surgical salvage. But we need to bridge this guideline void. Currently, our clinical management of lung abscess depends upon the weak evidence of case report, retrospective cohorts, and an antibiotic trial that was done way back in 2008. But what we need is a prospective randomized trials. We need more of antimicrobial stewardship data and more of evidence-based international guidelines to help us treat these patients better. Thank you very much for your patient hearing. Thanks.
Thank you, sir, for an excellent overview, and it was insightful learning for all of us. And there are a few interesting questions which the audience has posted. And one of the important, questions which always come in our mind when we see a patient of pneumonia, that we are treating a patient of pneumonia maybe in the ward or ICU. So what are the red flags or what are the signs when you suspect in a patient that he may be having a necrotizing pneumonia when you are treating the patient?
No, Dr. Prashant, we must do a CT scan because that is the first diagnostic criteria. And the CT scan, we find those multiple micro abscesses and multilobar involved. Then this is not just an ordinary pneumonia. It's a necrotizing pneumonia, and these patients have a higher mortality rate, a higher morbidity as compared to pneumonia, and they would require more aggressive treatment. So if you've got a localized patch of consolidation, maybe involving a segment or maybe localized to a lobe without showing any evidence of necrosis or cavitation, then this could be a simple pneumonia. But once we have these micro abscesses developing, then it, of course, is a complicated pneumonia and necrotizing pneumonia.
And what exactly, if you're treating a patient, we all see these patients, what will be the timing of a bronchoscopic sampling versus a image guided sampling in such a patient? When do you decide, maybe is there a criteria of antibiotic duration, or how do you, I know there is no clear answer for this, but yes, what is your experience? When do you do actually a image guided sampling?
So if you look at the guidelines, I don't say the guidelines, the current practice is that they would do a bronchoscopy when there is a possibility of an obstructed airway or the patient who is not responding to antibiotics. There may be a foreign body there. In those cases, they do it, but I would do a bronchoscopy practically in every case. Because I want to have microbiological diagnosis as early as possible for a targeted therapy. We have the pneumonia biofire available, so that can give us a clue very early as to what kind of infection it is there. And secondly, it is a tuberculosis endemic country where we want to rule out tuberculosis as a matter of fact. And if the patient has got a diabetes, and many times these lung abscesses come out to be due to mucor. In the case of bronchiectasis, the necrotizing bronchitis I showed you was actually a case of mucor. So if we had not done a bronchoscopy in these patients, we would have missed the diagnosis, just treated them with empirical antibiotics with antibiotic without the mucor coverage, and this patient would have died very quickly. So I would rather err doing early bronchoscopy practically in all the cases, depending on the fitness of the patient, and try to have early microbiological diagnosis for a targeted therapy.
Dr. Arjun?
Sure, sir. The question to our Bansal sir, because this has been asked multiple times by audience. Sir, are there any point of care tests that you can do clinically to distinguish between a complicated pleural effusion and a mnemonic effusion? While we are waiting for the reports, would a bedside ultrasound be useful? Would there be clues on a chest X-ray? So, is there anything that can be done clinically to distinguish between the two?
If we start with the chest X-ray, if you are able to see the meniscal sign, then clearly it shows that the fluid is probably free flowing, and that is why that meniscal sign is present. If you do an ultrasound in these patients, and you find free flowing fluid without any septations, without any debris, then chances are that this is a simple parapneumonic effusion. But if you find evidence of any septations, any debris, if you find lenticular opacities on the chest X-ray, and then you do the CT scan. Obviously, we are not talking bedside here, but bedside ultrasound, mainly the septations in the fluid will indicate towards a complicated parapneumonic effusion.
And so everyone talks about the role of lactate levels, pH and pH of the pleural fluid. So how does one really get the pleural fluid pH done? Do we do it in the ABG machine? Because a lot of labs, when people say that they try getting it done, the lab says that we can't do it. So how do you do it?
I mean, this is utter nonsense actually. I mean, I've had this problem for many times. When the ABG machine can take the blood sample, it can take a turbid fluid also. When you look at the pus, you're not going to do the pH because it is clearly empyema. But where do you do the pH? You do the pH when you have a turbid looking fluid where you're not sure. That turbid looking fluid is certainly less viscous than the blood is. Okay? So take the sample and read them immediately, and the same ABG machine should be able to give you the pH. And so it should not be difficult. The only problem is that it is not being practiced, and the people who are running the machine are not being convinced that it is safe to do that.
Sure, sir. A lot of things can be done on the pleural fluid. For example, when you do a pleural fluid NT-proBNP level in a patient with heart failure, we have this argument every time with our laboratory colleagues that, the resident on duty or the lab tech on duty would say, ye nahi hota hai. We can't do this in the pleural fluids. Same as with pleural fluid pH. It can easily be done with the ABG machine.
Absolutely.
And that's what all the guidelines are based on. So I think this is a very important message to all the postgraduates, the young pulmonologists who are here with us today, that start doing this. It does make a lot of clinical difference, and you would kind of, not miss a lot of patients. So your patient, the one that you showed, you had taken this guy up front for VATS. You did not wait for any tubes, or you did not, put any agents inside the pleura. I kind of also do that in my practice. It leaves a very neat scar, and everyone is very happy with it. But sometimes, the lines there are very, very gray. You really don't know what are the cases where you need to put in a tube early. The MIST trial has shown that sometimes things work, sometimes they don't. So any clinical reckoners there, sir, which tell us that this patient upfront should be, taken up for surgery?
So if you look at this patient particularly, if you look at the collection, was posterior. Now you don't want to put a chest tube posteriorly, which is going to be extremely painful, very difficult to drain. Also, there were multiple collections which were anterior also. So there was no fix. And the pleura, if you look at the thickness, was almost 6 millimeter in size, and the size of the cavities were almost 6 centimeters actually. Okay, so we knew that in this patient, even if we were to put the chest tube and we were to put the fibrinolytic agents, chances are that this patient will not actually be helped. So we decided based on clinical experience. So where do you put the chest tube and do the fibrinolytic quickly? Mainly acute patients. Okay, if you have a patient coming with pneumonia who is not improving, you find the fluid. Within 1 to 2 weeks' time, you put the tube in, put fibrinolytic agents. Most of these patients will actually do very well. And we still tend to use streptokinase in a number of patients, and it helps actually. So I don't know, this practice of putting TPA plus Nordnase has been the Western practice. And they actually do not like the streptokinase at all because of the antigenic properties. But we find it to be a cheaper agent and still very effective. So early use of fibrinolytic is the key to success.
That's a very important message. Yeah, you don't keep waiting till it's become really bad and thick and fibrous, and then you say it's not working. There's a very good paper, sir, by Professor Marva from RNR, where they've actually, because there's this problem with, streptokinase, because the guidelines clearly say that, no, you should not be doing this. The BTS guidelines have strict no against streptokinase.
Yeah.
So, medical legally, sometimes you might be in a fix if the patient bleeds. So, I think it's a very simple message that there are Indian papers on this, and urokinase has been shown to be effective just in case, you're scared of using streptokinase, though it still works. And the Indian Chest Society, sir, they're doing this paper because we had this huge argument last year at the ERS Delhi Congress where everyone said that they use, streptokinase. And one of the Americans who was on stage, he just got up and said, "Where is the data? Show me the data." And that's where, we Indians take a backstage. We do all these things, but we never publish them. We never bring them out. So I think the Indian Chess Society, I don't know whether they've actually done anything about it or not, but they said that, they're going to do a study. I'm still waiting. Let's hope that it gets done and we have some Indian data, because we all understand that we've been using this for a long time. It does work in some of our patients and it does prevent surgery. But as you've said, it has to be early. No joy of doing it when things have already become too thick, fibrosed, right?
And
Prashant,
the
sir.
other thing is, Arjun, we
Yes,
put
sir.
it 3 times. That's the another thing. We don't put only once, we put at least
Yes,
3.
sir.
No, you'd go on for 3 days. And also remember about the VATS also. If it is done early, something like within a month of having all these things, it works perfectly. Otherwise, most of these patients might go for proper decortication, open decortication. Okay, so that again is a problem. So early fibrinolysis, early VAT surgery actually works better than delaying the whole thing.
Prashant, sir.
A very interesting question. In a patient who's a partial responder to interpleural fibrinolysis, and you see the responses there, the drain has come and the X-ray or the ultrasound is improving, and there is some other small, pocket remaining. Would you repeat the course of interpleural fibrinolysis? And how many times you can do it? Actually, it's again a no answer question, but what is your experience? Have you repeated multiple fibrinolysis in a patient?
We have not done beyond 3 days in most of the patients actually, because we find that if that is not working and if the septae are not communicating with each other and it's not resolving, then there is no point of doing it. Rather, what I would tend to do is get the ultrasonologist to drain those different septations actually, if there is sufficient collection. So rather than trying to put the streptokinase into that, I would drain them separately.
The other thing in our country is the cost of surgery. This is why this, what Dr. was saying. Otherwise, if the cost was not a consideration, if
then of course.
it's not working, we'll go for surgery.
Yeah.
Absolutely.
So, sir, continuing with, one of your patients which you showed, there you did a VATS and then obviously, and we face this challenge frequently that there is an exudative, high LDH, high ADA, lymphocytic partially predominant diffusion. So would you do a pleural biopsy in such patients, or will you wait for initiation of ATT and give the antibiotic first? What is your approach for such patients who have an unclear tuberculosis, on the background?
Sure. So the advantage of VETs basically is that you get the tissue to do the biopsy and do the culture as well as do the gene expert. But let us say if you're not able to do that, in that case, CT guided pleural biopsy is a very good alternative to take a sample. And most of the CT people now get biopsy shown. You may not actually treat them with surgery, you just continue with ATT and steroids. They will do better results too.
Yeah, thank you, sir. And I think in our experience also we have used this. Plus, a lot of medical thoracoscopic biopsies, biopsies in such patients.
Well, you do VETs, the same thing as surgeon does it. You do medical thoracoscopy. The idea is to make it one cavity and take a biopsy sample.
Yeah, thank you.
What happens, Dr. Prashant, is, ADA is a very good marker, but if ADA is a young boy, presented with typical features of tuberculosis, there is no problem with start of ATT. Now, problem is when the ADA is between 40 to 70, and the clinical picture is also quite deceptive, right? Then you are not very sure. But in those cases, you can give a trial of anti-tuber treatment for 1 month and see whether the patient responded clinically or not and the fluid flow is resolved or not. But if after giving 1 month of ATT, in these borderline cases, you can go ahead with doing a medical thoracoscopy. But if there is atypical presentation, somebody who has got elderly, who doesn't have fever, who is a smoker, and coming to us, with an ADA of say 42, 43, I think in those cases upfront it's better to do a thoracoscopic biopsy rather than waiting.
Arjun?
Avdesh sir, so this is a clinical question. Someone who has been admitted with a pneumonia, and it is day 5 of admission today, and the guy has been on piperacillin, tazobactam, and say doxycycline. He's clinically improving. You do a screening X-ray or a CT scan on day 5 before discharge, and you see there's a pleural effusion over there. The guy has not deteriorated clinically. So what should be the algorithm at that time? You change your antibiotics, you hike them, you add something for staph, you drain this fluid, you put in a chest tube. So how do you proceed with this? Because this is something that we do see clinically very often.
Sure. So it depends on the amount of fluid and the quality of fluid, on the characteristics of the fluid on the ultrasound. So if the fluid is moderate to large in size, then obviously you have to drain this fluid mostly by either direct aspiration, because if this was an uncomplicated pleural effusion, then the treatment would continue to be the same except that you have drained the fluid. But if the fluid showed septations, if the fluid had other features of complicated parapneumonic effusion, then I would actually put a chest tube in these patients and wait for the antibiotics to continue. As I'm seeing clinical response with ICD, chances are that this patient would continue to respond even further.
Awesome. Manoj, sir, this one's for you. In your opinion, what is the role of doing a CT guided sampling of the lung abscesses? What are the complications? Because sometimes these abscesses say you're not able to do a bronchoscopy for a patient, but you need some kind of a microbiological diagnosis, and say tuberculosis is one of the DDs. So how safe is it to put in a tube, how to put in a needle inside a parenchymal lesion, a lung abscess? Is there chance of developing a sinus tract over there, or massive hemoptysis post procedure? Should you do that clinically?
So first of all, routinely we don't do it. As a matter of fact, not in every case of lung abscess we do it. Initially we start with anti-microbial therapy. We would do a bronchoscopic intervention in these patients, try to sample it, and try to give antibiotic for at least 7 to 10 days. In those patients who are not responding, and where my microbiology has been negative on doing a bronchoscopy, and then I'm in a desperate situation, then before doing a percutaneous drainage, maybe I can do a aspiration, CT guided or ultrasound guided aspiration for microbiological assessment. Now, there is a theoretical risk of causing all those complications you talked about. There could be pleural infection, empyema, hemoptysis, causing a pneumothorax, all those things. But these are very, very rare, as a matter of fact. I mean, this study, the literature does not show much of those complications. But having said that, we do not report our complications. We only report our successes. So we don't know actually what is the actual rate. But in our practice, we have seen these abscesses being drained with pigtail quite successfully without much of a complication. So it's quite safe. Please do it rather than fearing the complications.
There are adhesions. So
I
that's
agree
why
with Manoj.
complication is mainly bleeding sometimes in these patients. Otherwise, because there are so much adhesions, whatever you do, you will do inside the lung abscess only. And this is not done that often nowadays. People go for surgery. So that's why now this is, because if there is this is there, then patient is toxic, not responding to antibiotic. People go for surgery very early nowadays. And most of the time, as Manoj had shown, they do lobectomy or some resection of that area, because then patient gets better very fast.
Yeah, but I can give you another example of recently we've seen a patient who was 17-year-old girl, very thin, Wegener's disease, bilateral lung abscess of the size of 10 centimeter on both sides. And we actually ended up doing aspiration on both sides, putting pigtail catheters. The minute we put the pigtail catheter, empyema developed. So she had 4 catheters at one point, draining the empyema as well as draining, and it was jelly-like pus. So if you don't do that, this patient was not a candidate for surgery at all. And if you did not drain that pus, there was no way the patient could have got better. So
it has to be individualized.
it has to be individualized.
I think this could have got better with steroids alone.
Oh no! She had steroids and rituximab already.
Yes.
So, Chavla sir, this is for you. In the ICU, once you're dealing with these empyemas and lung abscesses, staph is always a consideration. So, for an intensivist, when you're treating staph, the options are between ticoplanin, linezolid, vancomycin, levonadifloxacin. So, how does an intensivist choose therapy for staph? How do you do it, sir?
If the renal functions are all right, vancomycin has the maximum experience. People go for this. But if you see by the penetration, linezolid is a drug which penetrates the maximum. But most of the people, because we have now a lot of experience with teicoplanin and end up giving teicoplanin. But all these three drugs can be used in these patients. But if the renal function is an consideration, then linezolid is a better drug. Or even teicoplanin can be given safely. Mostly what we do in these patients, that you give one of the vancomycin or teicoplanin when patient goes home. If it is sensitive, send him on linezolid or tedizolid, whatever.
And what about levonortifloxacin? So your experience with that?
I have not used much, but in our hospital, my colleagues in my even unit, they have a lot of experience. Even Dr. Akansha uses quite a bit. But I use not that often. I don't know about Mansur. What is his experience?
I'm an old timer. I'm still not using it.
Okay, sir. So because sometimes, linezolid has these silly, fancy side effects, neuropathies and strange side effects, especially in the elderly and the frail. So, and you've very rightly said that, at the end of it, we end up using teicoplanin, though we want to use other things. So,
Another important point is that if you have a naive patient, a young patient not exposed to risk factors, flucloxacin is another alternative which we have used successfully in methicillin sensitive staph aureus, and I am using it a lot in these patients. And continuing with this antibiotic thing, Dr. Manoj, we know the duration of antibiotic therapy is usually 4 to 6 weeks in lung abscesses or such complicated cases. What is your guide? What guide you take to titrate your therapy, clinical and radiological? And along with that, when do you actually refer the patient for surgery, if at all you have to?
So at least I would give IV antibiotics in these patients. So I would give antibiotic at least after 2 days of effervescence of the fever. That's the important. That takes at least 2 weeks, as a matter of fact. And once the patient becomes clinically stable, right, his hypoxia is corrected and the patient is feeling comfortable, then I would switch to the oral therapy, and then I would continue for at least another 4 weeks. So 6 weeks with the minimum of antibiotics in these patients. Now, patients who have not responded in 10 days time, high-grade fever is persisting or the cavity size is increasing, the sputum is also increasing. In those patients, the surgeons have to be involved early, as a matter of fact. So we do involve the urgency within 7 to 10 days. Maybe interventional radiologists also. So we have a MDT and decide as to what could be the best option. If we reach a consensus that first we do a percutaneous drainage, then we do a percutaneous drainage, and if upfront surgery is required, we do it. So I showed you a case where there was a necrotizing abscess and there was a myocardial aneurysm sitting within the cavity. Now this patient was actually sitting on the volcano. Patient has a sudden bout of cough, and this myocardial aneurysm would rupture and would have massive bleed. And this patient was not very symptomatic, as a matter of fact, but it took this patient upfront for the surgery. So it all depends upon what kind of cavity you have, whether there is a myocardial aneurysm is there or not. But majority of time we wait for at least 10 days to 15 days before going for any lobectomy in these patients. And this is also important because by that time the surgical risks will also come down, because at least some sort of infection will be contained. So that may give you a better surgical outcome as well.
May I come in? You see, if the lung abscess near the chest wall, then all these things are very easy. If it is in the center of the chest wall and you have a normal lung all around, then there is a problem. Then probably you should attempt these catheter unless person is extremely experienced, and I think go for a surgery early. I think, what do you have to say, Manoj?
Absolutely right. I totally agree with you. If it's a peripheral abscess,
Peripheral abscess,
PCD, but if it's a central abscess, no option. Go for surgery. Absolutely correct. Maybe in some of these cases you can try a bronchoscopic aspiration, but I'm not a great fan of bronchoscopic aspiration and lavage and drainage in these patients, because it has inherent risk, and majority of the time the pus is so thick that sort of a bronchoscopic aspiration and lavage would be unsuccessful majority of the time.
The other thing is, how long should we wait with antibiotics? If you started antibiotics, the abscess I was saying, when you should go for surgery, 1 week, 2 week.
Sir, patient not responding 2 weeks time, this is a very good time to intervene, as a matter of fact, because after that the risk for surgery will also increase. The patient will become more, trained physically, nutritionally, and I think the appropriate time would be 2 weeks. If you do it before 2 weeks, possibly it will be a little early. But yes, if you've got a myocardial aneurysm sitting in the cavity, then you don't wait for even a single hour and go for the surgery immediately.
Sure. Avdesh sir, this one's for you. So we've had this patient recently, 17-year-old kid with Down syndrome, has this very fishy history of fever for 2 weeks now. we do an X-ray and there is a thickened pleura, and you do a CT and there is a pleural collection which is very thick. Now you send this kid for a pleural tap and the radiologist says that you can't do anything. It's very thickened. You can't even take out an ml of fluid to test. And these are the patients where you get stuck. It's a 15-day kind of a history, so you don't know whether this is pyogenic or this is tubercular. This is a kid with Down syndrome. So how do we sample these kids? How do we kind of, because we've done a CT, there's no node there. We were looking for a node in the neck or the axilla somewhere if we could hit that. So how do you go around, managing these cases?
So clearly you need sampling with the help of imaging. And the easiest thing would be to do a CT guided biopsy in these patients. That's one way of looking at it. Second would be if the patient agrees or the parents agree to go for a thoracoscopic biopsy in these patients and find out what the disease is. The problem is most of the time they don't agree. So CT guided still remains one of the best modality to make a diagnosis in these patients.
Awesome. Prashant sir?
Yeah, I think this may be for Dr. Chawla actually. Sir, many times we have this patient of lung abscess or a necrotizing pneumonia, and patient lands on a ventilator. Are there any ventilatory considerations for ventilating this patient like we have for ARDS or this? I mean, is there anything different which people may do? And this is asked by one of the
There is,
attendees.
if they have ARDS associated, you will ventilate them lung protective strategy. Otherwise, also nowadays it is recommended that all patients you should do a lung protective ventilation. There is no specifically, unless there is a bronchopleural fistula. Otherwise, it will make a normal ventilation. If there is an ARDS, go by ARDS or just ventilate them. There is no special setting for these, but be careful that you do not have a very high blood pressure. If it is a peripheral and near the pleura, it might rupture also. So otherwise, there is nothing extra in these patients.
I think very
I can add.
the term is lung protective ventilation for all patients.
Dr. Manoj was saying
Dr.
something.
Manoj,
Yes, yes. I was just adding and maybe putting my point of view. So somebody with lung abscess who has gone on ventilator, possibly these cases become an early candidate for surgical resection, as a matter of fact. What do you say, sir, Dr. Rajesh?
Yeah, I mean, you should, but you have to stabilize them. The way he's saying,
Yes.
patient is on a ventilator, then it becomes easier to do surgery and then relieve them of the abscess. But these conditions, when we are talking, it appears simple. But let me tell the viewers, youngsters, these are very sick patients. They are sometimes very, very toxic patients, and you have to be careful when you are managing these patients.
Awesome. So,
We should
Manoj,
not
sir.
forget, the country rate. Yeah. So let me just want to add that, this is still the medical management is supposed to be better. It has a better outcome. The mortality with the surgery is higher. So we have to be very careful while, selecting these patients for surgery, because otherwise, again, the mortality rate may be higher by doing injudicious surgical intervention in these patients. So we have to be very careful, and we must do an MDT as a matter of fact, involving radiologists, the microbiologist, the pulmonologist, critical care specialist, surgeons. And we should do an MDT, document it, and then, intermediate radiologist, of course, and then document as to, you go for surgery or any other intervention.
Also, sir, ID people, they anyways come everywhere. So,
That's right.
yeah, they have to be there now everywhere. So,
If
sir,
the IV therapy is effective, then get them a PICC line and let them take injections at home. That also, you must not stop, because then it may come back. That also is very, very important.
sure, sir. So, Avdesh sir, if you have a patient who's come with a pneumonia and on day one, the patient's getting admitted and you see there's an infusion with the pneumonia on day one. So, does that affect your choice of antibiotic? Would you start this patient on meropenem with linezolid vis-a-vis just piperacillin on a guy who did not have an infusion to begin with? Just a patch?
No. I mean, see, you're treating pneumonia with a fusion basically. So it depends on whether it is a community-acquired pneumonia or whether it is coming. So you look at the setting. And if you look at the treatment of empyema, it actually follows the treatment of pneumonia. So if you have a simple parapneumonic effusion without any septations, no infection, nothing, and on day one it's almost impossible to prove that, you would start them with standard antibiotic therapy for community-acquired pneumonia. So you will not start them on meropenem or linezolid or other things basically. Okay. So the treatment.
That's a very important
Exactly,
message. Sure, because so effusions don't mean that someone needs
Effusion,
meropenem.
exactly. That's it. Okay, because as I said, these effusions will resolve on its own. If they are simple effusions, they'll resolve on its own.
Sure. And sometimes what happens is because these patients also have associated diastolic heart failure,
Yeah.
they're seeping into the pleural
Absolutely.
space, so they come wet. And when you treat the infection, you give them a little bit of diuretics, you hold their fluids,
Get better.
so they do tend to, and the sepsis goes away. So the effusion also goes away because there's sometimes a systemic element to the effusion as well.
Yeah. Yeah.
So one of the indication of using anti-staph coverage is the pneumonic effusion. So if there is a pleural fluid there, we must add the anti-staph coverage in these patients.
Sure. So in the right patient where there is, there's clinical features suggestive of staph and there's a history that the patient is immunocompromised, there are septations, then of course staph should be covered. That's a very important message.
I think post-influenza patients who
Post-influenza.
get secondary infection, okay, that is where the staph infection becomes very, very important.
And we are seeing a lot of influenza right now. So I think the sales of Ticoplanin are high. Yeah.
Thank you, sir. I think over to you, Dr. Chavla.
Yeah, I think I would like to thank Dr. Arjun and Dr. Prashant for so wonderfully moderating this session. There were still few questions I think left, but we are already over time. So I'd also like to thank Avdesh Bansal, who meets me every day. We are colleagues at Indraprastha Apollo Hospital. Dr. Manoj Goyal, wonderful talk, very nice slides, and he told the up to date on the lung abscess. And Dr. Kansha for, as usual, updating the last module. And also, I would like to thank the Hexagon for conducting the IT team conducting very nicely, and also the Zyme Biosciences for supporting this event. And on behalf of National College of Chest Physician, I thank all of you for sparing time and giving your 2 hours to 2.5 hours to discuss this important topic. So, and also the public which is already present, more than 800 I saw some time back. So I like to thank you also because it's you which is encouraging me to do all this. And next time we have a module 20, so 5 more to go after that, and it is on tropical fever and infectious, infective endocarditis.
Yes.
So I'm now forgetting infective endocarditis and tropical fever. So see you next Tuesday at 7:30. And there's another information, the module which is 21st, because the speaker had little time issues. So we'll have on Friday, that is on the 4th of September, we'll have 2 modules in the next week. So hope to see you there again next Tuesday and next Friday. Thank you very much.
I'd also like to thank Dr. Chavla and Akanksha for doing such a commendable job. I think Akanksha needs to be commended
Absolutely.
for doing this. I'm sure she could write a book now.
Thank you, sir. Thank you.
अगले हफ्ते 2 आकांक्षा buckle up.
Exactly.
Thank
And also thank you, Prashant, and thank you, Arjun, and thank you, Manoj, for being such a good partner in the crime today.
Thank you, sir.